Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's going on in this image? What should be on your differential diagnosis for this child with this swollen neck? I hope you have mumps on there. We're going to be talking about this and much more in this presentation on salivary gland pathology. This is covered in your book, Medical School Pathology and Step 1 Review. Scan the QR code to get to all the updated resources, right? Everything you need to succeed. Do your best on Step 1 and on pathology coursework in your med school. So salivary gland pathology. Well, as we know, saliva is produced by exocrine salivary glands, which are found inside the mouth, right? There are 3 pairs of salivary glands, 1 pair in each of the tongue, lips, and cheeks beneath the skin. Each gland consists of a duct that transports saliva from the gland's primary formation site to the duct's opening. Just behind the upper front teeth, the duct enters the mouth's floor, lubricating the area, allowing for you to properly chew and masticate your food, and importantly, swallow it without choking, right? That's always a plus. And since we're talking about salivary glands, what condition is there an autoimmune process that affects the salivary glands that causes the person to have a very dry mouth and trouble crying? Sjogren's disease, right? You remember that. I know you've heard of it. But back to salivary gland, right? Now, whenever one is awake, a small amount of saliva generally is always gathering in the mouth, and we refer to this as resting flow. Additional saliva is released while speaking or chewing or swallowing and yawning. This is called stimulated flow. The parotid glands produce most of the saliva produced in the body. They account for around 60% of the salivary gland's overall volume. They're about 2 centimeters long and 0.5 centimeters wide. Now, these are sizable glands. They are located above the bottom lip, under the earlobes, and on both sides of the jawbone. Near the corner of the mouth, the parotid glands protrude into the cheek. The submandibular glands, which are roughly 3 centimeters long and 1 centimeter wide, are smaller than the parotid glands in general. They are located close to the mandible bone, deep inside the neck. Their openings are situated at the jaw's angle. Less than 1 millimeter wide, the sublingual glands are very small. They are located right underneath the tongue and the floor of the mouth. Their entrances are concealed behind the tongue's underside. The oral mucosa is covered in small salivary glands. The hard palate, buccal mucosa, gingiva, labial mucosa, and ventral surface of the tongue all contain the majority of the glands. Numerous of these glands are located extremely close to the lymphatics, nerves, and blood arteries. Many of these glands have uncertain functions. Salivary gland pathology that you must be familiar with includes mumps, Sialadenitis, Pleomorphic Adenoma, Warthin Tumor, and Mucoepidermoid Carcinoma. Now, mumps can become inflamed and enlarged. Symptoms of mumps include pain, bilateral swelling, fever, headache, muscle aches, exhaustion, and the dreaded appetite loss. Symptoms of mumps usually appear about 10 days after being exposed to the virus. Rarely, The mumps can lead to life-threatening side effects such as brain infection, pancreatic inflammation, liver disease, testicular damage, sterility, and deafness. Now, what's sialadenitis? Well, sialadenitis is due to salivary gland inflammation, like you could see to the right in this micrograph. Now, you might be wondering, what is this? I just see pink and blue. So I'm going to tell you about it in detail, okay? If you take a step back and you look, you'll see geographic spheroid, dark pinkish blue areas, and then this vague intervening light pink area, okay? That vague intervening light pink area, that is fibrosis, right? And those islands of cells, right? Those are glandular formations, right? And if you look directly in the center, you'll see something that looks like a lymphoid follicle. That is the inflammatory infiltrate. And to the right, you can see a few more. And then you start seeing a lot more, right? You see those lymphocytes affecting the glands, chronic sialadenitis. Now, sialadenitis is usually on one side, unilateral, most frequently caused by an obstructing stone that leads to Staphylococcus aureus infection. Now here we have another image showing extensive lymphoid infiltrate with interstitial fibrosis and acinar atrophy. If you look at the bottom right and upper right, you can see the inflammatory cells very easily. Now let's move on to another condition that you will definitely be asked about because it's very common, called a pleomorphic adenoma. Pleomorphic adenoma is a benign tumor made up of both epithelial and stromal tissue, hence why it's called pleomorphic, because it's made up of more than one thing. Pleomorphic adenoma is the most common salivary gland tumor, okay? You must know about it. Here we can see a pleomorphic adenoma on ultrasound, right? We can't define it that way, but we can see it after the fact, after the diagnosis has been made by pathology. But keep in mind that pleomorphic adenoma appears as a moving, painless mass that is constrained to the jaw angle. Histologically, pleomorphic adenomas have a myxoid component and a stromal component. And they are often associated with the PLAG1 gene. Again, pleomorphic adenoma is associated with the PLAG1 gene mutation. You'll highly likely be asked that. Treatment of pleomorphic adenoma is surgical resection. Small islands of tumor that extend through the tumor capsule frequently result in an incomplete resection. There is a high recurrence rate for excised pleomorphic adenomas. Rarely, the benign pleomorphic adenomas may develop into their malignant counterparts known as carcinoma X pleomorphic. Here on the right, we have an abnormal presentation of a pleomorphic adenoma. Why is it abnormal? Well, because of this keratin plug in the center, right, and the one that's next to it. But for the most part, with pleomorphic adenoma, you should be aware that it's very common and that it's pleomorphic. There's a myxoid component and there's a stromal component, right? As well as the mutation PLAG1. Now let's move on to something else that you will definitely be asked about. Warthin tumor. I guarantee you will see this because it has classic histologic features. Now, Warthin tumor is a benign cystic tumor with a stroma that resembles a lymph node and many lymphocytes, right? You see that? You see all the lymphocytes in this H&E section? And you see the glands, right? Warthin tumor It's also known as papillary cystadenoma lymphomatosum, which better describes what's happening, right? It has a papillary component, a cystadenoma component, and lymphomatosum, right? It's having this inflammatory infiltrate, right? Makes sense? Warthin tumor is the second most common salivary gland tumor. And it's important to note that they often happen in elderly men that smoke, right? You might see that in the clinical vignette. Warthin tumor occurs almost invariably in the parotid gland. For example, we can see on this gross image of a Warthin tumor. And this H&E image of a Warthin tumor, right? Do you see the characteristic features, the papillary features, the lymphocytic infiltrate, right? Maybe you can see it with this image. Can you recognize the oncocytic epithelium? Do you see the lymphoid aggregates? Great. With that behind us, let's discuss another very important topic. Mucoepidermoid carcinoma. Now, a mucoepidermoid carcinoma is a malignant tumor made up of squamous and mucin-producing cells. Mucoepidermoid carcinoma is the most common malignant tumor of the salivary gland. Keyword malignant. A lot of questions like to trick you or throw you off, right? The most common is pleomorphic adenoma. The most common malignant tumor of the salivary gland is mucoepidermoid carcinoma. So look out for that term, malignant. Mucoepidermoid carcinoma often occurs in the parotid glands. And the facial nerve is frequently compromised by mucoepidermoid carcinoma. And since we're talking about the facial nerve, there's another key clinical aspect that you need to be aware of, this condition, right? Known as Bell's palsy. Do you remember the features for that? Ipsilateral inability to wrinkle the brow, ipsilateral drooping eyelid, right? That asymmetric smile because of the ipsilateral inability to smile, right? You remember that. Bell's palsy. So there we go. You completed another very important lecture. There's so much material in these lectures. I'm so proud of you for going through them and soaking up the knowledge. Share this with your friends. If you're a good friend, support them. Support them like I'm supporting you, okay? I want to see everyone who's putting in the work win, right? That's what it's about. Because at the end of the day, we need to be better physicians so that our patients receive the best care, right? That's what all of this is about. But in the meantime, I'm wishing you great success. Keep up the good work, and I'll see you later.